Good day, everyone. I am Dr. Meghna, a consultant hematopathologist from India. It is my pleasure to present today on a very exciting and rapidly evolving area in oncology, the AI-powered genomics and hemato-oncology, a paradigm shift in precision cancer diagnostics. Over the next few minutes, I'll walk you through how artificial intelligence, when combined with genomics, is transforming the way we diagnose, stratify, and manage the hematological malignancies. Moving on, the hematological malignancies are highly complex and heterogeneous. In clinical practice, we often encounter patients with the same diagnosis, such as either acute myeloid leukemia or lymphoma. Yet their clinical outcomes differ significantly. One patient may respond very well to the therapy, while another may relapse early or even show resistance. So, naturally, the question arises, why does this happen? The answer lies in genomic heterogeneity, meaning that each patient's tumor has a unique molecular signature. Now, building on this concept of genetic heterogeneity, let us look at how we traditionally approach the diagnosis in hemato-oncology. Traditionally, the diagnosis relies mainly on morphology, followed by immunophenotyping and cytogenetics. While these methods are extremely powerful, they do have important limitations. They are often time-consuming. Sometimes it is very subjective and not always sufficient to capture the full complexity of the disease. And also, we are now generating enormous amounts of genomic data and yet interpreting this data manually, which is becoming increasingly impractical and unsustainable. And this is exactly where the artificial intelligence becomes essential. So now, to better understand how we arrived at this point, let us briefly look at how the diagnostic has evolved over the decades. We started initially with the morphology, examining the cells under the microscope, and then came the era of immunophenotyping with flow cytometry, which added another layer of precision. This was followed by cytogenetics, allowing us to detect the chromosomal abnormalities. Subsequently, molecular diagnostics enabled the identification of specific gene mutations, and now we are in the era of genomics, where we can analyze multiple genes simultaneously. The latest addition to this evolution is artificial intelligence, which helps us to interpret this vast amount of genomic data efficiently. So today, diagnostics is no longer microscope based, it is data driven. Now, within this data-driven approach, genomics plays a central role in clinical decision making. It helps us in identifying driver mutations, performing the risk stratification, and guiding therapy selection. For example, in AML, mutations such as FLT3 and NPN1 have significant prognostic and therapeutic implications. Similarly, in CML, the BCR-ABL fusion gene is central to both diagnosis and the targeted therapy. To understand this challenge further, let us look at the next generation sequencing. NGS allows comprehensive mutation profiling, including the targeted panels and exome sequencing and even the RNA-based fusion detection. However, with this power comes significant complexity. A single sequencing panel may generate hundreds of variants per patient. Now, determining the clinical significance, including especially those VUS, that is variants of uncertain significance, it's very time consuming, variable, and highly dependent on the expertise. As a result, this often leads to delayed and sometimes inconsistent reporting. So that's where artificial intelligence comes into the picture. But what exactly is artificial intelligence? This is particularly a machine learning and a deep learning algorithms, which enables the computer to identify the patterns, learn from the data, and make the predictions. And all of this is happening at a very incredible speed. And importantly, AI can also handle high dimensional complex genomic data, which is exactly the kind of data that the genomics generates. So what would take hours or even days for a human expert can be performed by an AI in a matter of few seconds. It's not only improves the efficiency, but also enhances the accuracy and reproducibility. Now, let us briefly look at the different types of AI approaches which are used in genomic analysis. Broadly, there are two main types. The first is the supervised learning, which is also used for prediction tasks, where the model is trained on the labeled data. For example, it can predict diagnosis, prognosis, including the risk stratification and even the treatment response. The second type is the unsupervised learning, which is used for clustering, where the models identifies the patterns without predefined labels. in hemato-oncology, this is particularly powerful. That is the unsupervised learning depending on the clustering, which is very powerful because it helps us to identify the novel disease subgroups that may not be apparent using the traditional classification systems. So now translating these AI approaches into the real world practice, several AI tools are already being used in the genomic analysis. These include the platforms such as Deep Variant, AlphaMissense, and the Vasome. Each of these tools serve a specific purpose, from variant calling to pathogenicity prediction and also the clinical annotation. Together, they enable rapid and more accurate data interpretation of the complex genomic data. As a result, they significantly enhance the diagnostic accuracy and are increasingly being integrated into clinical laboratories worldwide. Now, to understand the true impact of these tools, let us compare the traditional variant interpretation with the AI-driven approaches. Traditionally, the variant interpretation involved manual review of databases, literature, and clinical correlations. This process is highly dependent on the expertise and can vary significantly between the observers. In contrast, AI provides rapid, standardized, and automated interpretation with highly reproducible outputs. It integrates the data from multiple sources and generates a prioritized list of clinically actionable variants. Thus, AI acts as a powerful decision support tool for molecular pathologists, not a replacement, but an augmentation of the clinical expertise. And as the volume and the complexity of genomic data continues to increase, the need for such intelligent support systems become even more critical. Because in reality, the scale of data we are dealing with today is far beyond what can be managed manually. So, however, the increasing reliance on genomic data also brings us with a major challenge. One of the biggest challenges with the genomic technologies is the sheer volume of the data generated. Each omics layer generates enormous data, and for a single patient, a sequencing run alone can produce thousands of genetic variants. Now, importantly, not all of these variants are clinically relevant. The real challenge lies in identifying the mutations which are pathogenic and to identify those which are benign and also to identify those which are of uncertain significance. Manual interpretation of such large data sets is time consuming, labor intensive, and prone to variability. This leads to major big data challenges, that is, storage, processing, and even interpretation. And this is exactly where the artificial intelligence becomes indispensable to handle this scale efficiently. So moving on to the next slide, we are all familiar with the central dogma of molecular biology. That is, DNA is transcribed into RNA and then which is translated into protein. In the context of the vast genomic data we just discussed, it is important to remember that this data does not exist in isolation. It represents different layers of biological information. However, in reality, this process is not strictly linear. It is highly interconnected and regulated at multiple levels. And this is where AI becomes important. It helps us to track these complex interactions, understand the regulatory mechanisms, and identify where the disease process originates. Now, moving on from the theory to the real world application, the AI powered genomics is already being applied in several areas, including leukemia classification, prognostic prediction, and the drug response prediction. For example, the gene expression profiling combined with the AI can classify the AML subtypes more accurately than the traditional methods. But beyond the classification, the AI also supports the clinical decision making at an individual patient level. And importantly, these diseases are not static. They continue to evolve over the time. So, and that brings us to an important aspect of the cancer, especially in the hematological malignancies, that is the dynamic nature of the diseases, which evolve over the time through a process known as clonal evolution. A tumor may consist of multiple subclones, each with different genetic alterations. Under the treatment pressure, the resistant clones may emerge and dominate. AI can analyze these longitudinal genomic data and track the changes over the time, helping us understand the disease progression and predict the treatment resistance. And moving on, ultimately, all of this will lead us towards the goal of the precision oncology, that is integrating the genomics and the AI. That means providing the right treatment to the right patient at the right time. Instead of a one-size-fits-all approach, therapy is personalized based on the patient's genomic profile in which AI plays a very important role in identifying these actionable targets and recommending the appropriate therapies, leading to better outcomes and reduced toxicity. This becomes even more powerful when we move beyond genomics alone, where AI integrates multiple omics layer. That is, we achieve better disease stratification, improved diagnostic accuracy, and identification of the novel biomarkers. This is particularly important in heterogeneous diseases like AML and also lymphoma. So if we summarize the key advantages, AI enables more precise diagnosis, reduction in the false positives, personalized treatment, and better prognostication. But beyond these advantages, AI is now transforming the entire hematological care continuum. It is used for treatment response prediction and highly sensitive MRD detection. Additionally, AI-powered decision support system assists the clinicians in personalized treatment planning, making a shift from reactive to predictive hematology. Moving on, AI in the lab hematology. This transformation is equally evident even within the laboratory. In laboratory hematology, AI is significantly improving the workflow efficiency and the standardization. It enables automated peripheral smear analysis, enhanced digital hematopathology, and intelligent triaging of abnormal samples. These advancements reduce the turnaround time and also improve the diagnostic consistency, especially in high volume centers. And then when we bring all the capabilities together, this is where the true paradigm shift occurs. AI systems can now integrate genomics, flow cytometry, cytogenetics, digital pathology, and clinical data into a unified decision support model. For us as hematopathologists, this represents a shift from the compartmentalized diagnostics to integrated precision medicine. To better illustrate this, let me present a few clinical scenarios. First, in this case of cytogenetically normal AML, the traditional classification relies on individual mutations. However, the AI integrates the mutation type, allelic burden, co-mutation patterns, and clinical variables, and thus generating a dynamic relapse prediction score, providing a more nuanced prognosis and supporting personalized treatment decisions. This is the second case. When in the case of diffuse large B-cell lymphoma, the morphology and HIHC provide the important clues. The AI integrates the mutational signatures such as MYD88 and CD79B in this case to classify the molecular subtypes more accurately. This is clinically important because certain subtypes have poor prognosis and respond differently to the therapy. And in the third case of minimal residual disease assessment, the low-level populations which are difficult to interpret, the AI models easily detect the subtle immunophenotypic changes and correlate them with the genomic clones. Even when the MRD appears low, the AI can predict early relapse risk, allowing timely intervention. This is the case 4, where AI was used to analyze the mutation kinetics over the time. Even the low-frequency mutations, which may initially seem insignificant, was tracked for potential expansion. This helped to predict the treatment resistance early and support the proactive therapeutic decisions. In the Indian clinical setting, resource optimization is critical. In this MDS case, AI-based models incorporating TP53 burden reclassified the patient from intermediate to high risk. This supports early transplant referral rather than ineffective therapy, improving both the outcomes and cost effectiveness in this case. These cases clearly illustrate that AI is not merely analyzing data, it is transforming the complexity into actionable clinical intelligence. And this marks the true transition from descriptive diagnostics to predictive oncology in hemato-oncology. While these clinical applications are promising, they also raise a very important question. Can we fully trust the decisions made by the AI? This brings us to the one of the most important critical issues in the AI, that is black box nature of many AI models. In clinical practice, it is not enough for an algorithm to simply provide an output. It must also explain how the decision was reached. This has led to the development of explainable AI or XAI, which improves the transparency through the tools such as heat maps and feature attribution. Explainability is essential for clinician trust, patient safety, and regulatory acceptance. Without interpretability, clinical adoption of AI will remain limited. Explainable AI acts as a bridge between the technology and real world practice. Moving on to the challenges. Beyond explainability, there are several broader challenges that impact the implementation of AI in clinical practice. These include high cost, data privacy concerns, need for infrastructure, and lack of trained personnel. Additionally, integrating AI into the clinical workflows remain a significant hurdle in a routine practice. These practical limitations are especially relevant in resource-limited settings. And beyond the technical challenges, we must also consider the ethical and the regulatory aspects. Currently, there is a lack of standardized global guidelines for AI in healthcare. Regulatory approvals require rigorous validation, and many AI models are still evolving. Another critical issue is algorithmic bias, which can lead to inequitable outcomes. There are also questions of accountability. Who is responsible if the AI makes an incorrect decision? These issues must be addressed before AI can be safely integrated into routine practice. So, what's next? Looking ahead, the future of the AI in hematology is highly promising. We are moving towards seamless integration into clinical workflows, real-time diagnostics, and innovations like federated learning, which allows the data sharing without compromising the privacy. Additionally, continuous learning systems will allow the AI models to evolve over the time. Together, these advancements are bringing us closer to truly data-driven and intelligent cancer care. So, to conclude, genomics has fundamentally transformed the oncology, especially hemato-oncology. But while the genomics provide vast information, it is AI that enables us to interpret and apply it meaningfully. Together, they are driving a true paradigm shift in the precision diagnostics. And most importantly, AI is not replacing the clinicians. It is empowering us to practice better, more informed medicine. And with that, I would like to thank you. Thank you for your attention. I would be happy to take any questions. If you have any further queries, please feel free to reach me out at my mail, meghanap.mp@gmail.com. I would be happy to respond. Thank you.
Presentation. My presentation title is Mutation in exon 7 of BRCA1 gene in Bangladeshi women with triple negative breast cancer. And I am Dr. Priyanka Sharma, Assistant Professor, KMSS Medical College, Bangladesh. July title. We all know that the nature breast cancer is the most common cancer of women worldwide. Like Western.
Hello, Dr. Priyanka. Sorry for the interruption.
Yes.
Doctor, we can't able to hear you clearly properly. There is a break in your voice.
Okay, now it's here.
Hello, Dr. Priyanka. We can't able to hear you properly.
Now it's here.
There is a break in your voice.
Thank you so much.
Am I audible?
Yes.
Yes. Okay. Okay. Now, according to WHO, breast cancer is the most common cancer in women worldwide. Like Western countries, it is now increasing in Asia and remaining a major cause of cancer-related mortality. As we know that breast cancer is a complex disease with a heterogeneous spectrum of tumor, and this heterogeneity, which is due to genetic, epigenetic, and transcriptomic changes, as well as varying clinical findings and treatment options. So, within a heterogeneous disease spectrum, different breast cancer subtypes are frequently encountered. On the basis of immunohistochemistry, breast cancer are classified molecularly into 4 types, and triple negative breast cancer is one of the aggressive molecular subtypes. Now we know about triple negative breast cancer or TNBC. The TNBC is defined as no or absence expression of estrogen receptor, progesterone receptor, and human epidermal growth factor receptor 2. The TNBC is commonly associated with large tumor size, high grade, and younger age at presentation. As it is the hormone receptor negative tumors, so it is very difficult to establish the targeted therapies. And due to lack of targeted therapies, it leads to worse prognosis and early recurrence that leads to poor survival. The global incidence of TNBC is 10 to 15% of all invasive breast cancers through the frequency varies by population. The epidemiology suggests that about 60 to 80% cases of BRCA1 mutation carrier have a lifetime risk to developing breast cancer, and the triple negative breast cancer has a strong association with germline mutations in BRCA1 gene. So the frequency of BRCA1 mutation is as higher as 10 to 15% in triple negative breast cancer. In India, a systematic review and meta-analysis estimate pooled TNBC prevalence rate is 27 to 31%. The prevalence of breast cancer is also high in Bangladesh. In Bangladesh, lack of knowledge, negligence of disease, limited access to the treatment are responsible for the fatality in the breast cancer. And there is a most significant things that the risk factors of breast cancer in different molecular subtypes may vary. For example, early menarche, having no children, and late menopause are associated with breast cancer, whereas the younger age at onset, parity, race, and contraceptive uses are associated with triple negative risk. So, the clinical relevance of triple negative breast cancer extends beyond its epidemiological proportions. So, my objectives of the study is to find out the mutation in exon 7 of BRCA1 gene in Bangladeshi women with triple negative breast cancer. And my specific objectives is to find out the frequency of the mutation, to find out the socio-demographic characteristics of my study subjects. Now my methodology. This is a cross-sectional descriptive study conducted under the Department of Biochemistry, Dhaka Medical College, in collaboration with Institutions for Population and Precision Health, the University of Chicago, United States of America, from January 2022 to December 2022. Total 34 diagnosed triple negative breast cancer patients who are attending the outpatient department of radiotherapy, Dhaka Medical College Hospital, and the surgical oncology department of Bangladesh Medical University were selected as a sample and by purposive sampling technique. Now my study procedure. At first, I collect the sample. A informed written consent was taken from my study subjects after explaining the purpose and procedure of the study. And blood samples are collected before starting chemotherapy and radiotherapy. The blood samples are collected from the arm vein and it is kept in the EDTA continuum tube to prevent any clot formation. Then I process the sample for the coding and labeled and coding for identification. These all samples are preserved at minus 20 degrees centigrade temperature, and when all the blood samples are collected, the whole blood was sent to the University of Chicago on dry ice for subsequent DNA extraction and sequencing. Now the laboratory procedure which occurs in the lab to the University of Chicago, the Institutions for Precision and Populations of Health. Here at first we do the DNA extraction, as the DNA is important for the study of the genetic cause of any disease. The DNA was extracted from the whole blood, and the DNA was extracted using quick DNA TM mini prep kit. Quality control and concentration of this DNA was measured by nanodrop 1000. Then the library preparations by enzymatic fragmentation. The enzymatic fragmentation was done to get a fragment size of 180 to 220 base pair. Then twist universal adapters are ligated on both the ends. Twist library preparation kit provides the reagent needed to prepare genomic DNA. We generate the library with a unique pair of index for 34 samples. We combined all the 34 library to make a dual indexed library pool. Then we hybridized the pool with custom designed props. After hybridization, a magnetic beads, that is streptavidin beads, was added to the pool. The streptavidin would only attach to the double-stranded amplified enriched library. This enriched library was then captured and purified by magnetic beads, and the other DNA fragments were washed away. Then only this enriched library was PCR amplified again. This is the final product for sequencing, which is again checked by bioanalyzer mainly to check the base pair sizing. For concentrations, here we use Quantas. And finally, for the targeted DNA sequencing, we used custom designed twist next generation sequencing kit. Then I discussed my result of the study. As my specific objectives is to find out the socio-demographic characteristics of the study subject, I saw the frequency of age in different age groups. This is the histogram showing the frequency of patients in different age groups. Here the age ranged from 26 to 65 years. And the largest proportion of the women was in the 41 to 50-year age bracket, indicating that the majority of women were in their 4th and 5th decades at the time of diagnosis. Another socio-demographic history of the study it includes the obstetric history, contraceptive history, and family history. In obstetric histories, the parity profile of the study populations is described. Here, multiparous was predominant, followed by nullipara and primipara. We can see that the multipara occupies more than 70% of the study subjects, and the high proportion of multiparous women is representative of the general pattern in Bangladeshi women. So, the relationship between parity and triple negative breast cancer in these populations considering an important data. Now, contraceptive history. In this table, we can see a mixed idea about the contraceptive associations with triple negative breast cancer. Here, about 47.1% people did not use any contraceptive in their lifetime, but remaining 52.9% uses different types of contraceptives. Among them, 47.1% uses oral contraceptive pill. The other contraceptives contribute 5.8%. So, in this table, we have a mixed idea about contraceptive uses. But it's also important data to diagnose the triple negative breast cancer. Now the family history. Here, the majority of the patients did not report any family history of breast cancer in their first degree relatives. Only 5.9% had a positive family history. This low family history indicates that triple negative breast cancer is mostly sporadic with a negligible contribution of hereditary factors to its etiology. Now, the number of variants of the study subjects. Here, we prepare the 34 library for the sequencing. And in my total sample size is 34. After sequencing, there was no variations is identified. So the frequency of my variant is 0%. This is the picture of the exon and introns of a BRCA1 gene. This is a picture from my study subject which shows no any polymorphisms or no variables in the structures, and that's why I mentioned that there is no mutation is detected. And it is the nucleotide base sequence where the nitrogenous bases are mentioned through different colors. Here the adenine is identified by red in color, whereas the guanine yellow, cytosine blue, and thymine is green. In this sequence, the nucleotide bases are sequenced in a normal pattern. There is no any change or no variable or no simple polymorphisms is detected. That's why I can say that there is no mutation is found in the exon 7 of BRCA1 gene in these study populations. In 2018, Dr. Mehta et al. Conducted a study about BRCA1 and BRCA2 gene in the North India, and he found one novel mutation in the exon 7 of BRCA1 genes, and their mutation frequency was 3 to 2%. This study inspired me to do such a study in the Bangladeshi perspectives, and that's why I do the study in the Bangladeshi perspectives. But in my study, there is no mutation in exon 7 of BRCA1 gene. But when the whole BRCA panels was learned, then some exons like exon 10, exon 12, exon 11 showed many variants respectively. So the result was similar with another study which was conducted by Dutchkelly and Kanjimir in 2021. They also found variations in exon 10, 11, 12 and did not in exon 7 of BRCA1 gene, which is similar to my study. So, in the conclusions, I can say that triple negative breast cancer in Bangladeshi women mainly affects the women in their fourth and fifth decades of the life. Multiparity and oral contraceptive usage is notable in the women's association features. And women suffering from triple negative breast cancer in the Bangladeshi perspectives have no mutation in exon 7 of BRCA1 gene. As my sample size is very small, so I can suggest that the mostly sporadic nature of triple negative breast cancer in this population suggests the need for large scale populations level screening and awareness programs. These are the references I have used to prepare my study, and I am grateful to all the authors which references I have used in this study, and I am also grateful to all the participants who provided the valuable data for this study. Thank you. I am happy if you send any queries or questions about my presentations. You are welcome to my mail dr.priyanka.saha@gmail.com. Thank you.
Hi, so good afternoon, everyone, and thank you for the opportunity to present today. So my name is Dr. Daniel Crompton, and I'm based in the UK. Today I'll be presenting a recent case report that myself and some colleagues published. It was titled Peritoneal lymphomatosis, which was mimicking an advanced ovarian malignancy, a diagnostic challenge in DLBCL. So, in terms of a background, diffuse large B-cell lymphoma is the most common aggressive non-Hodgkin lymphoma. Although extranodal disease is recognized, diffuse peritoneal involvement is relatively uncommon. In comparison, diffuse peritoneal disease is much more commonly associated with metastatic cancer, particularly gastrointestinal malignancies or ovarian malignancies. And as a result, sometimes imaging findings can often lead to sort of uncertainty regarding the clinical diagnosis. So this case in particular just highlights the importance of maintaining a broad differential diagnosis when imaging appears slightly atypical. So in regards to this specific case, it was an 82-year-old lady who was admitted initially with a 5-week history of progressive dyspnea, fatigue, and reduced appetite. Her symptoms had gradually worsened over several weeks, and she also described a productive cough and bilateral lower limb swelling. Initially, the clinical picture was thought to represent just a persistent chest infection, and she'd completed 2 outpatient courses of antibiotics prior to admission without meaningful improvement. Despite this, the symptoms continued to progress, raising concern that some sort of underlying process may be driving her current presentation. And importantly, for this case in particular, prior to this illness, she had been living independently, driving and managing all her activities of daily living, and she had a performance status of 1. In terms of her examination, it wasn't nothing really sprung, obviously. She had mild abdominal distension with shifting dullness. She has reduced bibasal air entry, bilateral crackles, and a palpable right cervical lymphadenopathy. Interestingly, her pelvic exam didn't reveal any obvious pelvic mass or significant gynecological abnormality, despite later imaging appearances suggesting strongly of such health. At this stage, the presentation remained relatively non-specific, although her cervical lymphadenopathy later became an important diagnostic clue in retrospect. In regards to her initial investigations, the chest X-ray just showed bilateral fluid infusion. The most notable blood abnormality, which was she was slightly high. Her albumin was on the low side. She had elevated LDH and she had a significantly raised CA125 at 337. At this stage, does raised CA125 kind of further reinforce suspicion of an advanced ovarian malignancy? So she underwent a CT imaging of her thorax, abdomen, and pelvis. As you can see in slide 1, it demonstrated that she did have ascites and some diffuse peritoneal thickening. On a further slide, you can see that she had some slight omental caking. Taken together with these appearances, that strongly suggested that the patient had some sort of ovarian malignancy. The only sort of uncertainty with this case at the time was her extensive lymphadenopathy was also identified, including mesenteric, para-aortic, and mediastinal node involvement. This distribution in particular was atypical for a primary ovarian malignancy and raised suspicions of an alternative diagnosis. The diagnostic challenge here was most most of the initial examinations and initial imaging pointed towards an ovarian malignancy, but some of the symptoms were just very atypical for that and pointed towards the signs of a lymphoma. An excisional cervical lymph node biopsy was performed eventually. Histopathological examination demonstrated atypical lymphoid cells with vesicular chromatin and prominent nucleolia. CD20 positivity confirmed B cell lineage as well. So in particular with this image, there's partial on this particular image, the arrows point to some of the tumor cells which demonstrate CD20 positivity. And these findings were consistent with diffuse large B cell lymphoma with peritoneal involvement. In terms of why this case matters, this case is clinically important because lymphomas can closely mimic advanced ovarian cancers, both clinically and radiologically. Ascites in the mental caking may easily direct clinicians towards an ovarian cancer pathway, particularly when it's accompanied by a raised CA125. But I think, however, CA125 does lack specificity, and may also arise in conditions causing peritoneal irritation or inflammation. In this case, in particular, the major clue favoring lymphoma was the presence of the extensive superduff lymphadenopathy, and not all lamenting caking is ovarian cancer. And for this scenario, it's important to get an early biopsy to prevent diagnostic delay and the patient receiving their treatment. In terms of just having a look at the literature that's out there at the moment, peritoneal lymphomas is quite a rare presentation of a lymphoma and is much less common than the peritoneal spread from ovarian or gastrointestinal cancer. One of the main challenges is that the imaging appearances can look very similar. So several published cases out there describe patients initially being investigated for ovarian cancer because of the findings similar to the patient, but then it's later to be found that it is a lymphoma. And across the literature, one of the most important features suggesting lymphoma is the extensive lymphadenopathy, particularly involving nodes above the diaphragm. This is clinically important because lymphoma and ovarian cancer require very different management approaches, and lymphomas may still be quite treatable if recognized early. For this reason, many reports emphasize the importance of early tissue biopsy when imaging findings appear either unusual or atypical. Just a table to show in terms of some of the similarities you find in terms of ovarian cancers and lymphomas. Ascites tends to be quite common in both, along with peritoneal thickening. What tends to be sometimes a little more niche is you don't necessarily see a mental caking in lymphomas, but it can occur. Lymphadenopathy should always raise a suspicion of a lymphoma, and you find that nodal involvement above the diaphragm tends to point towards more of a lymphoma picture. In terms of this case, this patient was discussed with MDT review, and due to the advanced age and decline in functional status considered, the patient wasn't deemed for any further intensive chemotherapy. She was treated more in terms of best supportive care and transitioned to hospice care with focus on comfort measures. So, in terms of take-home messages, for diffuse large B-cell lymphoma may rarely present with extensive peritoneal involvement and closely mimic advanced ovarian malignancy. CA125 isn't necessarily specific for ovarian cancer and may also be elevated in other conditions. And extensive superdiaphragmatic lymphadenopathy should prompt considerations of lymphomas. Yeah, these are the references I did use, and thank you for listening. Any questions at all?
Yes? Okay. Perfect. Well, good night, everyone. Thank you for this opportunity to present my investigation. I'm Jose Pinto Llerena, medical oncologist from Panama, from the hospital Anita Moreno. And my investigation titled Colorectal Cancer in Young Adults in Panama, Clinical, Molecular, and Epidemiological Characterization in a National Cohort. This is the larger real-world evidence or real-world data set from Central America and the Caribbean until now. Well, first of all, remember that colorectal cancer is the third most common malignancy worldwide and the second leading cause of death globally. But for the population under 50 years old, is underrepresented in most trials. But what we see in right now, sustained increase across North America, Europe, and parts of Latin America, like Panama, for example, over the last 2 decades. But what is the problem in Latin America with this population in general? We have lower survival than high-income countries. For example, our 5-year survival rate in Latin America is only 30 to 35%, reflects access gaps to screening, molecular testing, and biologics. So why early onset colorectal cancer challenges modern oncology? Well, young adults often present with locally advanced and metastatic disease with adverse histologies like mucinous and signet ring cell. Burden is disproportionate, and Central America and the Caribbean remain underreported in most trials. But why Panama? Well, remember Panama is a Central American country. We are an Hispanic Caribbean health corridor. So for that part, we have this first nationwide cohort of early onset colorectal cancer in the country, based in two national oncology referral hospitals, integrated clinical, molecular, survival data. And first, we have limited regional evidence about this topic. Two, distinct risk profile, because we need to prove that tobacco, alcohol, or growing overweight obesity can interact with this population. Three, therapeutical actionable biology, like alteration of the RAS pathway or MSI high carry direct implications of treatment, and public health relevance, because nationwide data are needed to inform screening, referral pathways, and equitable access to modern systemic therapy. So for this investigation, we have four main objectives. That first of all, to characterize clinical, molecular, and therapeutic features of early onset colorectal cancer in Panama. Second, to quantify overall survival at 1, 3, and 5 years. Third, to identify independent prognostic factors for mortality through multivariable Cox modeling. And fourth, to contextualize findings against international and regional series to inform to a policy in Latin America. The study design was a retrospective cohort conducted from 2020 to 2023, based on electronic health records from the National Oncology Network of Panama that included two national public oncology referral hospitals. Our inclusion criteria was patients aged 94 years old or below, that is called early onset colorectal cancer, with histologically confirmed colorectal cancer, and exclusion criteria were patients missing essential dates like diagnosis or follow-up, or without histologically confirmed colorectal cancer. As we see in the stroke flow diagram, we can see that we screened 414 patients, but only 242 met the criteria for the final analysis. We have a broad range of variables for our investigation. Demographic, for example, age, sex, and province. Clinical, like stage, ECOG, primary site, and histology. Molecular, like RAS status and MSI status. Behavioral, like use of tobacco, alcohol, obesity. Treatments like surgery, palliative systemic treatment, or use of biologics. And outcomes, which our primary outcome in that part was overall survival. About the statistical analysis, we use medians and proportions for baseline characteristics, overall survival estimated by Kaplan-Meier method, group comparison with log-rank test, multivariable Cox proportional hazard models for prognostic factors, including relevant variables like stage, ECOG, grade, recurrence, sex, age group, histology, laterality, and RAS. The results reported by hazard ratios with 95% of confidence interval and analyzed in the software Stata version 18. And our protocol was approved by the Institutional Bioethics Committee and conducted in accordance with the Declaration of Helsinki. Well, moving to the results, in our cohort of 242 patients, we have a median age of 41 years, with a slightly predominance of 52% of female sex, and this is in contrast with the masculine or men predominance in other international cohorts. That is something new for our cohort, and with a good performance status in the most patients, with 93% approximately. Well, something surprising for us is that 71% of the patients were diagnosed in an advanced disease staging with stage 3 and stage 4, and nearly half of patients debuting or diagnosing in stage 4. Most part of the patient, most of the patients were diagnosed with distal tumors. In this case, rectum, primary in 35%, and 82% of the patients with adenocarcinoma, not otherwise specified. Well, moving to the clinical epidemiological characteristics of our population, most of the patients aged between 41 to 49 years old, and we have rare cases below 20 years old. 33% of the patients carry at least one comorbidity. First of all, hypertension, followed by diabetes. And about the staging, well, nearly half of patients in diagnosis with a stage 4 disease, and overweight obesity was the most common modifier risk factor for our population in 44% of patients. About the geographic distribution, what we found that most populated provinces in our country has most cases. Okay, cases mirror Panama's population density, with 44% of patients in the Panama City, the most populated province in our country, followed by Panama Oeste, Chiriquí, and Colón. But why it matters? Well, it matters because heterogeneity in case distribution suggests geographic disparities in risk, detection, or registry capture in our country. About the tumor distribution, as we see, most patients have a distal localization of the tumor. In first place, rectum in 35%, followed by sigmoid localization. And about the histology, 82% had an adenocarcinoma nose, but we have an overrepresentation of other bad prognosis histologies like mucinous and signet ring cell carcinoma, both linked to peritoneal dissemination and poor survival. About the molecular profile for the overall population, 36% of patients has RAS mutation. That, remember, that is a bad prognosis for this type of patients. But when we focus on stage 4 disease, almost 61% of patients has a RAS mutation that contraindicate anti-EGFR treatment, for example. And about the MSI high or deficiency of a mismatch repair, approximately 8% of patients has a MSI high that can predict response to immunotherapy. But the most surprisingly data of this or result of this molecular profile is that MSI status was not assessed in 72% of patients, a lot of patients without possibility to apply to immunotherapy because we don't even know what is the result for these patients. So it is a fail of our public system in the molecular profile of our patients. About the behavioral and metabolic risk factors, we found that obesity or overweight was the principal modifiable risk for our patients, but less toxic driven carcinogenesis for our patients. We have a lower use of alcohol or smoking than international cohorts. Family history of cancer in 90%, but very interesting, only 11% of patients has a family history of colorectal cancer. That can show us that more of our patients has sporadic colorectal cancer. And about the treatment landscape, chemotherapy was administered to almost 100% of patients. Curative intent surgery in 60%, and radiotherapy predominantly for rectal primaries. Palliative systemic therapy was used in 65%, but only 40% of patients used biologics like bevacizumab or anti-EGFR treatment, with a recurrent documented in almost 18% of patients with multi-site metastasis in 70% of patients. This pattern reflects high advanced stage burden and limited biological and immunotherapy access in our population. But this is something that differs or contrasts with the most international cohorts for this population. For the most common metastatic site is liver for colorectal cancer, but in our population, peritoneum counts for 21% of the metastatic spread, being the dominant site for our population. Why this is happening? Because of the overrepresentation of mucinous and signet ring histologies in our patients can predict the frequency of peritoneum dissemination, implicating dedicated peritoneal staging, surveillance imaging, and consideration for cytoreductive surgeries or HIPEC that is not available in our country. Moving to the outcomes, we can see that the median OS or overall survival was 34 months with first year OS of 78%, decreasing to 49% at 3 years, and only 32% as 5-year OS, lower than international cohorts or high-income countries, for example, with a good median follow-up of 22 months that is adequate reliability for us estimates. And we found in the multivariable Cox model 4 independent predictors of worse overall survival. Stage 4, ECOG more or equal than 2, poor differentiation and recurrence. About the discussion, we have to find this deserve particular emphasis. In this case, first of all, the female predominance as contrasts with most international series in which men predominate. But what is the possible drivers? Regional differences in health-seeking behavior, different risk factors. We have a very common metabolic dominance over toxic-driven carcinogenesis in our population, and could reflect a true biological signal for Panamanian cohort. The second is the predominance of peritoneal first spread, and a typical signature for this type of cohorts may be driven by mucinous and signet ring histologies over representation in our cohort, demanding dedicated peritoneal staging and surveillance, maybe the use of more advanced surgical statements for this population, and the use of HIPEC in carefully selected cases. For public implications beyond Panama and across low and middle income countries, first of all, earlier detection, maybe tailor screening strategies for younger patients, not only older. Second, universal molecular testing is not optional. It's obligatory for this population because we have we need to direct inform anti-EGFR immunocheckpoints inhibitor for this population. And third, equitable access to modern therapy, expanding biologics, immunocheckpoint inhibitors, or use of HIPEC in public oncology systems, not only Panama, across Latin America. And about my conclusions, we can conclude 4 principal things. First of all, in Panamanian cohort, we have an advanced stage disease that dominates in this early onset colorectal cancer and is associated with poor or limited 5-year survival, only 32%. 2, peritoneal burden is high because of an overrepresentation or rare histologies with poor prognosis. Third, 4 prognostic levels, stage, poor performance status, histologic differentiation, and recurrence independently predict mortality in our population. And 4, a policy roadmap, scale early detection to youngers, universal molecular testing, obligatory, not optional, equitable access to modern evidence-based therapies. And for me, something very important is that a good quality real evidence for Central America are both feasible and necessary to change our politics in health systems. So thank you so much for this opportunity. I don't know if you have any question.
Okay, so I will begin our presentation. So thank you so much for giving me this chance to presentation. I'm Suyeon Jung. My research topic today for presentation is biologic aging and cancer. Particularly, I will focus on, let me see. Okay. So particularly, I will focus on the effects of behavioral factors on aging, the biological aging process, and their interplay with behavioral factors in cancer, the development. So I'm Suyeon Jung. I'm Associate Professor, UCLA Translational Research Section. In the School of Nursing, I'm a joint associate professor in the Department of Epidemiology, Fielding School of Public Health. And I have been involved in the cancer training programs, the molecular genetic cancer epidemiology training program, and genomic analysis and interpretation training program in the School of Medicine at UCLA. I'm a faculty member in genetics and genomics graduate program in bioscience. So before I move on, I want to briefly talk about the background. So aging is strong, the predicting the factor for age-associated diseases such as obesity, coronary heart disease, stroke, and diabetes. So the chronological age is well-established risk factor for chronic diseases, particularly for cancer. Aging is the strongest predicting factor. The breast cancer and colorectal cancer are the most common cancer types and the main causes of cancer deaths in women. And more than 80% or 90% of new cases of cancers developed in women aged 50 years and older. So these are the age-related diseases with a sharp increase in incidence after menopause. However, there is a substantial variation in cancer development, cancer incidence among individuals with the same ages. So indeed, the individuals of the same chronological age may accumulate the changes at different rates. So there is a heterogeneity in biological aging process between individuals of the same age. So what is biological aging processes? So aging can be viewed as a gradual decline in biological function, what we call biological aging, which is correlated with various molecular alterations. So lifelong exposures to environments and behavioral factors may influence various biological aging processes at molecular levels, leading to cellular dysregulation, epigenomic instability, and the mitochondrial dysfunction, as well as telomere attrition. However, these difference in biological aging process at the individual level may be only partially explained by genetic mutations. So alterations in DNA methylation, which is major epigenetic modifications, are known to be the most accurate readout of aging. It captures the influence of both genetic environmental factors and their interplay across time in cellular functions. So aging can be considered a reduced stability of epigenetic marks and epigenetic deviation from chronological age. So there are several epigenetic clocks, as we know, developed And they capture well the influence of genetic environmental factors and their interplay across time in cellular functions. And they are highly accurate multi-tissue marker for aging, strongly correlated with chronological age in different tissues. So what we did here, we examined the deviation of epigenetic clocks from chronological age among elderly women who prospectively developed breast cancer and colorectal cancer. So in this project, we examined whether pre-diagnostic peripheral blood lymphocyte-based DNA methylation clock is associated with prospective development of breast cancer and colorectal cancer. We further examined what degree the cancer risk prediction is modified by selected lifestyle factors. So we used the data from the largest ongoing prospective cohort of postmenopausal women in the US, which is Women's Health Initiative Study. You can see the website here, the details, information. We include more than 1,000 healthy women at enrollment, including more than 200 breast cancer and colorectal cancer development. For the validation, we used the cancer tissue data set for the colorectal cancer and for the breast cancer development, TCGA data and GEO data sets. For this project, we developed the 3 epigenetic clocks, which include, I'm sorry, HOBAS, a pan-tissue predictor, and Hanoum's clock, which is a peripheral blood lymphocyte-based clock, and finally the Levin's whole blood and the phenotype-based clock. And we estimated 2 parameters, epigenetic aging phenotype parameters. First one, the DNA methylation difference, which is defined as departure of methylation aging clock from chronological age, calculated by subtracting chronological age from DNA methylation clock. Another one is intrinsic epigenetic aging acceleration, IEAA, which is the residual from regressing methylation clock on chronological age, adjusting for blood cell proportions. So I'm not going to review all the results that we produced, but briefly talk about some key results here. We first examined the correlation between epigenetic clocks and chronological aging among the non-breast cancer patients in the left side, and in the right side among the breast cancer patients. In both types of the patients, they shows like strong the correlation between aging clock and the chronological aging. The same pattern shown in the colorectal cancer patients. You can see in both cancer and non-cancer patients. In the left side, you can see non-Hispanic, the whites, and the right side, non-Hispanics, African American. There is a strong correlation between epigenetic clocks and chronological age. And next, we examine the effects of epigenetic clocks on the lifestyle factors. Particularly, we are focusing on in this slide the BMI. So you can see in the box graph on the left side, and the line graph on the on the left side, and the line graph in the right side, compared to those with normal, the BMI, those women who are extremely obese have a higher aging acceleration phenotype. And what about the physical activity in terms of aging acceleration? As we expected, those with compared to those with physically inactivity, the women with physically women who are physically active had the lower aging acceleration, the phenotypes. And we also examine the effect of one of the important reproductive the factors, which is bilateral oophorectomy, the both ovary, the removal on aging acceleration. So you can see compared to those who didn't undergo the bilateral oophorectomy, those with both ovary removal have higher aging accelerations. So actually, the bilateral oophorectomy reflects the premature loss of ovarian function before natural menopause, which increases the risk for premature deaths and age-related deaths or the age-related diseases. And next, what about the association between epigenetic aging clock, aging acceleration, and the cancer development? We categorize women into the two groups: aging acceleration phenotype, which is ACC, the red line, and the decelerated aging group, which is DCC, which here the green line. So compared to those with DCC, decelerated aging group, the women with ACC, the positive deviation of aging, epigenetic aging from chronological age had a shorter cancer-free interval. And same pattern shown in terms of colorectal cancer development. We particularly focus on non-Hispanic whites here. So compared to those with DCC, decelerating aging phenotype, the women with aging acceleration, the group have higher, 3 times higher the risk of developing colorectal cancer. So finally, we want to study the joint effects of aging acceleration and the bilateral oophorectomy on cancer development. So given that the both ovary removal was associated with increased aging acceleration, we evaluated the effect of the oophorectomy status on increased risk of cancer as they biologically older. So in both tables, you can see those with both ovary the removal have 5 times the higher risk of developing breast cancer for a 1-year increase in aging acceleration, or almost 30 times higher the risk of developing colorectal cancer if they are biologically older. So our finding have an important clinical implication about the role of epigenetic aging markers in identifying an early risk group to provide tailored intensive screening for their breast cancer and colorectal cancer prevention. Particularly, the slide reflect and suggest is a protective effect of estrogen on colorectal cancer and the breast cancer tumorigenesis through the the estrogen receptor, the beta, that leads to anti-inflammatory and anti-proliferative mechanism. So I think I'm done. So thank you so much
for listening this presentation. I'm happy to take questions and discuss about future research directions and potential collaborations. For those who are interested, please contact me. Thank you.